Got my own picture here. Yeah, we got it. Good morning, good afternoon, and good evening. We're pleased today to present a webinar jointly arranged between Mangeshkar Hospital in Pune in India. Dr. Gandhi is hosting this webinar, and we have Dr. Bharati from Mysore as a speaker from India. And we have also a joint webinar. This is a joint webinar between the University of Chicago with Brandon Baird, assistant professor in Chicago. And then we have Ben from Mayo Clinic. So we have a wonderful gathering of two continents. And I'm in the UK moderating this session. Little bit about me. I qualified in 1960. That's quite a long time ago, 63 years ago. And my first job was in ENT. And I've been doing ENT for the last 60 odd years. I'm also vice president of British Medical Laser Association and a secretary general of European Laser Association. My special interest is in lasers. Now, we should start the actual scientific program first, and then I'll introduce Sachin Gandhi has a program. Have you? Sachin?
Yes, sir. Yes, sir.
So can we start the program and then Brian? Who is the first one, Brian?
I'll be the first.
Yeah. Mr. Brandon.
Brandon, yeah. Brandon, we haven't got your short CV, we've got a long CV. So can you introduce yourself briefly?
Sure.
And please continue.
Sure. Thank you so much.
Thank you. And the program is going to be 4 speakers for 15 minutes each, followed by a panel discussion, which is about 20 minutes, and then question answers from the audience for 10 minutes, and then we'll conclude the program. Okay, Brandon.
Thank you so much, Dr. Oswald. I appreciate it. I appreciate the introduction. And I'll talk as I'm pulling up the screen here, but I'm from the University of Chicago. I'm an assistant professor there. And I have the fortune of being able to participate in this wonderful gathering and this really great discussion. Today, we're talking about recurrent respiratory papillomatosis. It's a very near and dear topic to my heart. I see a lot of papilloma patients in the Chicagoland area here in the United States. And I'll briefly be talking initially about the diagnosis and the preoperative considerations, as well as counseling for patients when you see them for the initial consultation. As a representative of the American contingent, along with Dr. Bayan here from Mayo, I just want to thank our collaborators for involving us in this session, and we'll get right to it so we don't waste too much time. So the outline for my discussion is briefly a quick background of papilloma. A lot of you all are very familiar with that, but we'll briefly talk about that as sort of an introduction here. We'll breeze through that, and then we'll discuss some of the diagnostic considerations and the workup of RRP, and including both imaging and also an understanding of pulmonary involvement. We'll talk about preoperative and perioperative considerations, as well as the informed consent and family discussion component of treatment, and a workup for all of this, as well as some of the anesthetic and operative considerations. And finally, we'll briefly talk about the HPV vaccine, steroids, and some of the post-operative considerations for patients that are undergoing treatment for papilloma. So briefly, background, RRP, recurrent respiratory papilloma, it's a benign disease caused by human papillomavirus. It's notable for growths of papilloma anywhere along the aerodigestive tract. It has a bimodal age distribution, with young children, juvenile sort of is less than 20, being more aggressive usually at birth, and young adults greater than 20 is sort of what's considered in the adult form, and more common in men, that adult form, with incidence being 4 per 100,000 in children and 2 per 100,000 adults in the United States. A little bit more background. In children, the infection typically occurs through transmission through the birth canal of infected mothers. However, transmission has also occurred prior to birth via placenta in about 12% of cases. Typically, the presence of anal genital warts during pregnancy is considered a risk factor. And in adults with oral genital transmission, the considered mechanism is basically through the birth canal, with HPV 6 and 11 being the most common infectious subtypes of papilloma, with 11 being known for its increased virulence and also malignant transformation. Dr. Barathi will get into that a little bit more, I believe, during the discussion. So with diagnosis, patients tend to present with either hoarseness or airway obstruction. In the juvenile onset version, it's most commonly dyspnea due to the anatomic differences between the pediatric and the adult airway. And in adult patients, it's more commonly hoarseness, although patients can present with an array of symptoms, cough, hoarseness, etc. Gold standard for us for laryngeal papilloma diagnosis is laryngoscopy or endoscopy. This is done in the office, as many of you know, and it's confirmatory for any papilloma along the entire oropharyngeal oral cavity or laryngeal tract. Narrowband imaging can sometimes be useful as an adjunct for diagnosis. Basically, what you'll be looking for is the presence of like capillary loops or vascular abnormality. And narrowband imaging is included in many of the different scopes that are available, including Olympus, as well as Pentax has their own version of narrowband called iScan. Patients that have an identified laryngeal papilloma should undergo a pulmonary evaluation and surveillance with regular imaging. So this is a picture of what narrowband imaging looks like. And you can see the distinction between white light here and narrowband imaging. And there's sort of more of a prominent vascular pattern that you can see, this sort of polka dotted pattern that helps you identify the difference between aberrant papilloma and some of the normal arborization in the native vocal fold. With regard to imaging, CT with contrast of the chest is suggested for all patients with an initial diagnosis of RRP to evaluate pulmonary disease. There was an article that Forbes published in 2017 looking at some of the findings in patients that have tracheal bronchial pulmonary papilloma in 16 patients. And they found that the most common finding in about 87% of patients were just nodular formations along the tracheal wall. However, 2 patients had parenchymal involvement, and in some of the patients, they also noted some cavitated and also solid lung nodules in about 87% of patients. Other patients had masses, air trapping, and consolidation. So all things to kind of pay attention to. And the reason that it's important is because, especially for pulmonary disease, there's a risk of transformation into malignancy, which will be discussed later. Is there a role for PET CT scan in patients that have a diagnosis of RRP? Well, there is some evidence that came out initially in 2009 suggesting that by Sitsko et al., suggesting that there was utility in the in PET scan application for patients that have pulmonary disease. However, there is some concern about its positive predictive value, especially in the setting that many of these cavitated lesions having some underlying infection and potentially having a false positive as a result of metabolic activity secondary to infection rather than malignancy. It does, however, identify cellular proliferation in the lungs. So these are just sort of some pictures of what cavitated lesions look like. You all are familiar with this. And then what the FDG avidity looks like with solid nodules in the lung to help distinguish sort of malignant versus non-malignant foci. So briefly moving on to our discussion of informed consent and family discussion. So for many of these patients, you're dealing with children here, and a lot of times there's a difficult discussion that's had with the parents. I see many adult patients, and there's also a difficult discussion that's had with the patients. Many patients ask about some of the implications with regard to transmission, which sometimes can be oral genital. There's also a discussion about whether or not there is a long-lasting implication. And I always tell my patients that this is sort of one of the longest discussions, and also the residents, I tell my residents that this is one of the longest discussions that I have in clinic, because you really have to set the patients up for the expectation of what the treatment of papilloma entails. It typically entails treatment for recurrent disease. So you take the patient to the OR You take out all of the papilloma and it comes back in 3 months. You have to sort of telegraph that in your discussion with the patient initially, so that they are mentally prepared for the idea that there might be recurrent disease. You'll have to sort of make the patient aware that there may be recurrent or multiple procedures that are necessary. You also may have to discuss the idea that there may be fluctuating voice quality in very inopportune times, especially for some of our most vocally demanding or vocally active patients like teachers and lawyers. You may also want to sort of start to telegraph the idea of office-based management, which Dr. Bayan will get into a little bit later, as well as the use of adjuvant treatment like bevacizumab to keep some of the disease at bay. So an evaluation from the European Archives of Otolaryngology came up with this consensus statement with regard to how to have these types of discussions for suspension microlaryngoscopy, at least. There was no specific focus on papilloma itself. However, they did discuss some of the considerations specifically with regard to short and long-term complications of microlaryngoscopy. They also discussed the really important concept of talking about recurrent disease with microlaryngoscopy, and the risk of anterior glottic web formation, specifically with papilloma, as well as the risk of anesthesia, specifically for many of our patients, pediatric patients with obstructive papilloma. There can be concerns with regard to airway, securing the airway, and so that's an important risk to have preoperatively as well. You wanted to have a discussion with the patients whenever we're discussing suspension laryngoscopy about permanent voice loss. And Dr. Oswald, do you mind muting for me, Dr. Oswald? Can you mute for me, Dr. Oswald, if you can? And then airway obstruction risks with need for prolonged endotracheal ventilation or tracheostomy should always be also be discussed as well. This is a discussion about the role of vaccination in Gardasil. Many of the parents and or patients ask, is there a role for vaccination or the use of Gardasil, which is the HPV vaccine, in patients that have papilloma? And there is some literature to suggest that there actually may be some benefit if you have a diagnosis of papilloma to getting the HPV vaccine even after exposure to HPV. In this article, they looked at only about 12 patients or so, but they looked at the number of surgeries that were required for patients with aggressive disease prior to vaccination, and then they compared it to the number of surgeries that were required post-vaccination, and they found that that number went down by about 7-fold in sort of the post-vaccine group. This effect was also seen in an article by Matsui evaluating the the efficacy of vaccination in papilloma burden prior to and post-vaccine, and they saw a very similar trend. However, there's a contrasting evidence by Harai et al. In 2017, which demonstrated that there was limited seroconversion, or at least long-term seroconversion after the HPV vaccine. And only about 3 out of 11 patients had persistent seroconversion, meaning creation of antibodies against the HPV and antigens. And there was no significant association between those who generated antibodies for HPV 6 and or 11 and the presence or absence of disease. So I think that there's still the jury's still out. I think that most of the evidence sort of does support there is a great benefit to risk ratio, so it probably can't hurt. But there's still some unknown about the mechanism or whatnot of vaccination. So moving on to operative management and some of the anesthetic concerns, you want to preoperatively optimize as much as possible the patient, specifically the PEDS patients, and talk about specifically obstructive papilloma, which we'll go into in just a bit. Endotracheal tube selection and airway management is an important component of this preoperative decision-making. Whether or not you use a laser tube, if you use intermittent apnea, you may have improved access to the posterior commissure, but it may be somewhat more tenuous from an airway standpoint. Subglottic jet ventilation and the theoretical risk of papilloma dissemination is an important consideration as well as the consideration or the decision to avoid tracheostomy if possible, because you can seed disease through the tracheotomy site. Finally, a lot of these patients do undergo an intermittent apneic anesthetic approach, and total intravenous anesthesia should be considered. It's called TIVA with propofol and remifentanil for some of these patients. In terms of monitoring of the depth of anesthesia, there is something called a bispectral index monitoring system, which basically uses EEG waves to identify, theta waves specifically, identify the depth of anesthesia and to help not only with induction, but also emergence from anesthesia. And then there are some preoperative discussions with your anesthesia colleagues about steroids or no, and we'll get into that a little bit later. Bo et al. Released a article in 2011, discussing the examination and evaluation of patients prior to intervention. They also highlighted the fact that, as we mentioned before, obstructive papilloma can oftentimes become complete, turn from partial to complete when there's laryngeal muscle relaxation, and papillomas can prolapse into the airway. Patients with laryngeal papilloma suffer from anoxia, which can cause various degrees of laryngeal obstruction. And you need to assess whether or not that airway obstruction can be life-threatening and have plans B, C, D, and E ready to go with regard to securing your airway. Additionally, you want to make sure that you have advanced preparation of all of your surgical tools prior to induction so that you're ready, as well as any drugs or equipment you might need for potential cardiopulmonary resuscitation. Obstructive papillomata. So in children, you want to maintain spontaneous respirations with sufficient topical anesthesia. Usually 2% lidocaine spraying on the cords and the larynx at the time of induction can be helpful. Most anesthetics involve induction with low levels of propofol so that the patients are breathing on their own, as well as sufentanil and midazolam to keep the patients breathing. And then placement of suspension laryngoscope while also ventilating using an endotracheal tube near the larynx is also a consideration and also recommended. So how do we choose the endotracheal tube or the type of endotracheal intubation versus apneic ventilation? Some of the considerations include how much disease burden there is. If there's a significant amount of disease burden, that might preclude the actual endotracheal intubation. However, if there's concern for airway loss, then it may be the safest thing to do. You also want to consider whether or not in intubating endotracheally, you're potentially seeding disease distally into the proximal trachea, into the bronchi. Intermittent tracheal intubation can result in hypoventilation with some hypercarbia, so that's an important metric and thing to follow. Conventional jet ventilation has the potential for airway trauma, barotrauma, and pneumothorax. However, there's an option for a monsoon subglottic jet ventilation, which is a Accutronic machine. It's currently not being, it's paused, shall we say. But there's also an associated or anecdotal risk associated with dissemination of the disease. That being said, the catheter that's used for the subglottic jet ventilation using the monsoon is about 1 to 2 millimeters in size, so it can be a good alternative in a pinch. Finally, this sort of actually originated in Europe with you, Dr. Oswald. The transnasal humidified rapid insufflation ventilatory exchange, or THRIVE, is a high flow nasal cannula oxygenation that allows for continuous oxygenation by flushing out the anatomic dead space with a highly turbulent oxygen flow. Khan et al. Described the experience at Stanford University in 172 cases and found that despite the high oxygen concentration, the risk of intraoperative adverse events was 0 in 172 cases. There were no airway fires, and they were able to have a safe lasering, both using the KTP and the CO2, as well as the microdebrider in patients. And about 22.7% of those cases were papilloma cases. Finally, operative setup. You want to make sure that you have adequate exposure of the larynx. Killian was one of the first to perform suspension laryngoscopy and noted the and was able to suspend actually the patients from the ceiling and was able to use a bimanual operative technique with illumination using a headlight. That has evolved now into multiple other types of suspension laryngoscopy. Many of the types of fulcrum laryngoscopy that are used specifically for the DITO or pilling don't necessarily provide as much anterior commissure exposure. So the universal modular scope and the gallows suspension do allow for the elevated vector suspension that is great for access to the anterior commissure. And external counterpressure, as you can see with this, the tape, can actually bring the larynx into view and allow for an improved exposure and treatment. And then finally, ergonomics are an important consideration with regard to the treatment. So you want to make sure that you have an appropriate chair and that you're appropriately trending the bed towards a reverse Trendelenburg position. Finally, I'll talk about steroids and then voice rest. postoperatively. So steroids typically contraindicated with papilloma. There's not super great evidence, but in the OB-GYN literature, there's increasing evidence that steroids can worsen the effect of disease. There are a couple of articles that came out looking at specifically patients with asthma, both severe and non-severe asthma, and the degree of aggressiveness of the RRP. They found that in patients with asthma, they had slightly increased aggressive RRP, and specifically those that had inhaled corticosteroid use, they had a much more higher concentration of aggressive RRP. Granted, this was only in about 17 patients with aggressive disease, 7 with asthma, and 5 with inhaled corticosteroid use. However, it is compelling evidence to stay away from steroids in the setting of RRP. And then finally, voice rest. There's no specific evidence-based recommendation for voice rest in papilloma. Coombs et al. In, I believe it was 2013, looked at 172 ENT surgeons, and they did a survey that determined what their practice was in terms of voice rest. About 40% of patients put patients on voice rest after papilloma surgery, and about 36.1% of respondents placed them on voice rest for 1 to 2 days, and about 26 placed them on voice rest for 3 to 5 days. And this study was repeated in the United States. Joshi et al. Looked at U.S. laryngologists, and most respondents put patients on voice rest for about 0 to 10 days, prioritizing voice rest based on the degree of dissection. As you can see here, the green bar, they ranked that as sort of the most important reason for longer voice rest versus, say, the type of phonosurgery or the lesion type, which is sort of ranked as the third highest rank. So that's it for me. Sorry for running over a little bit, but I'll turn it back over to Dr. Oswald to present our next speaker. Yep. And I think you're muted again. Sorry. Thank you for muting during that. Yep, you're muted, Dr. Oswald.
You need to unmute, sir. Doctor. Hello.
You're muted. You're muted.
Unmute.
Madam, you can start. Yeah.
Yeah, I'll share my screen then.
Yes, yes. Yes,
Can you hear me now?
Yes.
Yes, sir.
yes, sir.
Okay, okay. Professor Bharti is from Mysore, India. She is a president of the Indian Association of Laryngologists. We might have met at some time in the conferences, but I can't remember. But what we've done is we've given the next topic to Professor Bharti. As we know that the spread of this webinar is global, as well as, more importantly, I think it's Asia Pacific region, where the socioeconomic diversity doesn't allow surgeons the best of the equipment that's available maybe in USA and UK and many other advanced countries and advanced cities in India as well. So we've asked Professor Bharati to give us some information about what other instruments we can use if you don't have the laser. Of course, when I started, there was no laser and we had cold instruments, cold steel instruments. So maybe we should know a bit more about those old methods when you don't have the laser, but more importantly, during a procedure, if the laser fails, you should be able to complete the surgery with cold surgery instruments. So, Professor Bharati, please go ahead.
Yeah. Thank you, Dr. Osan, sir. Actually, before I start my talk, we all should understand this disease is a disease of both medical management as well as surgical management. We need to do the surgery, but we need to hand over to the medical line management. That is, the surgery is to establish the airway and to minimize the trauma to the phonatory as well as the airway, that is the larynx. So with these principles, when we understand, we know how to go about it's the irrespective of the technology, whether you use cold steel, whether you use laser, whether you use coblation, whether you use microdebrider, your aim is to reduce the injury to the normal tissue and you remove the diseased tissue to establish the area. So now I'll be talking about the first is the coagulator. So the term is derived from the controlled ablation, and it's a combination of radio frequency energy with natural normal saline solution. This technology uses the principle that when an electric current is passed through a conducting fluid, a charged layer of particles known as plasma is released. So this, when the radio frequency current flows in the saline conductive medium, it creates a plasma field in the sodium chloride, and a charged free sodium ions are released, which then breaks the intercellular molecular bonds, and this causes the disintegration of the cells. And the literature also supports the use of the coagulation in the benign papillomas of the larynx. These are the literature. I'll just show the video. One is the adult papilloma and another is the child. So what we do is we have the laryngeal MLW van, and then we use that. And I've not shown, sorry, I've not shown how the setup of the surgery is. And is the endotracheal intubation. And when too much of anterior commissure is involved, then we stage the procedure. Otherwise, there is no need, because the main advantage of the coagulation is there is less thermal damage to the surrounding tissue, and it acts as 70 degrees centigrade the solid. So less thermal damage is there. So the healing is good. And whenever we are doing with the instrument, you can palpate and you can just remove the tissues without injuring the normal tissue. And also, whenever required, we remove the endotracheal tube, and then in the apneic episode, we do the surgery. We keep the endotracheal tube, that was the last, and then in the hypopharynx, and then we remove the disease, and then put back the tube. This is at the end of 8th day. So following that, depending on like when we have progressed, we give the intralesional. Either these days I'm using bevacizumab. This is another one which we thought adult papilloma. Then on the table, I did the biopsy, it proved to be squamous cell. At the same time, I did the cordectomy. I'll not go through this. There's another papillomas, both sides adult. This is the post-operative picture. Now, the second instrument is a microdebrider. Microdebrider is good. The only problem with the microdebrider is the bleeding is there. Whereas with coagulation, you can coagulate also. It has a dual mode, ablation mode and the coagulation mode. Whereas here, microdebrider, it only sucks and cuts. It has a rotating blade. So it has three components: console, it's controlled by a foot pedal, which determines the speed and direction of the rotating blade. And handpiece, it controls the blade and integrates the suction. And we have the blades, various types of blades are there depending where you are using the microdebrider. In the laryngeal blade we have, and the rotation we keep is between 500 to 1000. Depends on what console we are using. Advantage, dual mode suction and cutting, and quick debulking. Tactile sensation is there. Whenever we always with these instruments, we have the tactile sensation. We feel the tissue and then we start a cutting, and absence of thermal injury and less aerosol generator. And another thing is when the bulk of the lesion is too much, then we can debulk and then we can go for the laser. Once we have debulked and established the airway, we can go for the laser for the base, so that it will be controlling the bleeding also. This is almost, I think, this is the 8th recurrence the patient had who had come to me. So after just palpation, you can see how it's sucking and cutting. And at this patient at the end, I could get like this. And then we give the interrelational injections. Now, what are the adjuvant therapies we have and why we need these adjuvant therapies? These are required because as we go through the pathophysiology of the disease, we know that we need immunomodulation in these patients, and we need to disrupt the HPV reduplication, and we need to control the inflammation and also prevention of angiogenesis. So these are the basis for our use of adjuvant therapies. And we have all this antiviral, mumps vaccine also was used, interferon and cis-retinoic acid, HSPE7, PDI, PD1 inhibitor, and then photodynamic therapy, cimetidine, and then celecoxib, bevacizumab, HPV vaccination, and the indole-3 carbinol. Now, coming to the interferon, in the initial phase, when we all know, like when we prove that this is a HPV virus, then everyone like over could upward use interferon. But there are various studies using interferon in the respiratory papillomavirus, especially in the juvenile. And then these are various studies which showed, but none of these are replicable. That is, in one group had a good response, but the other group, they did not have a good response. When we tell good response means it is not that it will not come back, but the recurrence can happen, but it will, the remission period is prolonging over a period of time. And then finally, when the child becomes, the immunity of the child is regained, or it stops, auto-stopping of the reduplication of the virus happens, then the patient will have a cure. So this is the interferon. And then one study treated 11 adult papillomatosis with PEG interferon alpha 2A in combination with granulocyte. And then they said that out of 11, everyone had on the follow-up, no recurrence of 1 year follow-up. Then celecoxib, actually, we all know there is overexpression of COX-2 in the papillomas of the RRP patients. And this increase was proposed to be a consequence of epithelial growth factor receptor and phosphatidylcholine 3 kinase signaling. So they started using celecoxib, and I think we can use, I mean, it all depends in the adult we can use because it doesn't cause any harm. And then antiviral, I think I'll not be touching on cidofovir, only acyclovir. And there are also many studies using acyclovir. It's a DNA polymerase inhibitor and hence effective against DNA encoded viruses. Post-operatively, 80 milligram per kg per day is given in divided doses, maximum 3,200 milligram per day for 2 months. And various studies have shown that they have got good results, but none of these results were reduplicable. And then programmed cell death protein. And actually, this is present on the surface of the leukocytes. It negatively regulates the immune system when it binds to ligands PD-L1. And PD-L1 has been shown to be highly expressed in HPV-associated head and neck cancers. So with this, maybe it is also expressed in papillomas, and we can use 200 milligram of pembrolizumab, but it is very expensive. So in India, we are not using it. HPV vaccination, Dr. Bradson had already covered it. We have, just going in detail, we have 3 types of vaccination, HPV2, HPV4, HPV9. 4 is important because it covers for 6, 11, 16, 18 quadrivalent HPV types, which are important for us because 6 and 11 are the common one which is present in human papilloma, I mean, in respiratory papillomatosis. And then HPV9 also is there. And in India, coming to the India, we have, but it is not a national program, even though it's not made so mandatory that everyone should. But because of the awareness and because of the prevention of the cervical cancers, it is being used in various hospitals. And the amount, the cost is, it varies between 3,000 to 4,000 for the HPV4. For HPV9, somewhere around 10,000. And the dosage is 1 at 6 months if it is 9 to 14 years of age in females. Whereas if it is more, the adult, then adult up to 45 years we can give. That is 0, 1, 6 months. And coming to the, you can use HPV vaccination in patients who are approved with RRP. And then even with the age of 2 years, they have used HPV vaccination with good results. And approximately 110 countries, a third of target population have introduced HPV vaccination program to prevent cervical cancers. And a good study has been done in Australia and USA, and they've shown decline in the incidence, where Australia have covered with 12 to 26 years in 2007, And then when they did the study afterwards, the 0.16 per lakh, 1 lakh in 2012. So it's 2.022 per 1 lakh in 2016. So much of a reduction is there. And even in USA also, they have found the reduction in the incidence of the respiratory papillomatosis. Coming to the mumps vaccine, there are studies where they have shown that because it's quite cheap and available, after removing the papillomas, you would just apply on the surface either the mumps vaccine or the MMR vaccine. Inexpensive, readily available, non-toxic, remission-free duration increased in some studies. These are the studies. Anti-reflux medication, maybe. I think the anti-reflux, how it helps is because whenever you have, because it reduces the epithelial damage, so the seedling of the virus is prevented. Maybe this is the mechanism with which this anti-reflux medication helps. Then indole 3-carbinol, this modifies estrogen metabolism to alter cellular proliferation and DNA synthesis. And indole 3-carbinol is rich in broccoli and cauliflower. And also the tablet is available 200 milligram BD. And we have one study which showed that they had the remission rate prolonging with use of indole 3-carbinol. I think with this, I conclude my talk.
Thank you. Yeah. Thank you, madam.
Yeah, Dr. Sachin.
Yeah, thank you. Mute. So, mute, yeah.
Right. Can you hear me now?
Yes,
Can you
sir.
hear me now?
Yes, sir.
Sachin Gandhi, yeah. Thank you very much for that overview of surgery for papillomas. If you don't have, of course, the laser. And there are many ways to get there. Some are better than the others. But I think you should know your equipment, what you have, and optimize its use. There's no one particular instrument better than the other at an expert hand. So I think after this, these two very useful presentations, we go to our host, Dr. Gandhi, who is a head of the department in Mangeshkar Hospital, and is a founder member of the Laryngology Association, Laryngology and Voice Association, and also as a program director at the Mangeshkar Hospital. So he started these grand rounds last year. They were very successful. And this year, of course, we got a joint presentation between ourselves, that's Mangeshkar Hospital in India, and the University of Chicago. So this is a good step forward, Sachin. I'm very happy to say I met Sachin 20 years ago, and we have a long association. So let's hear from you about the lasers that you're expert in.
Yes, thank you, sir. We'll just go few slides about the anesthetic considerations. I mean, we in India get few or good number of patients with obstructed larynx, especially with RRPs, that is in children. We have a 3-year-old child presenting with stridor in the outpatient department and extensive papillomas obstructing the airway. And again, whether to do tracheostomy, how to intubate, whether to use jet ventilation, which Brandon has already talked about, or whether to have high frequency, high flow nasal oxygenation, or Thrive, what he has touched upon. Just few slides to mention the instruments we use in our clinic and could be useful in emergency situations. I think tracheostomy, all of us know, better to avoid because it may cause seeding of the tumor and maybe extension into the lower respiratory tract. But in emergency situations, we just have to put in the tracheostomy. But after debulking or removing the papillomas, we should try to decannulate the child as early as possible. Endotracheal tube from 3.5 to 5 millimeters. We should also know about laser resistant tubes if we want to use laser in debulking and making the airway open, or maybe for improving the voice. Because in children, the anatomy and situation of larynx, intubation may be difficult and may require video assisted intubation. So anesthetists do have this Macintosh with a video screen, video camera, or what we do, we use our sinus endoscope along with the Macintosh and help the anesthetist to visualize the larynx on a screen and pass in the endotracheal tube along the side. So video assisted intubation may be required, and sinus endoscope and video trolleys are available in almost each and every operation theater in most of the places. Jet ventilation, again, Brandon has already talked about. We also have to remember when we pass in the tube, it may carry the papillomas into the lower respiratory tract. This instrument, actually, I should introduce. This is called as ventilating bougie. I think most of the anesthetists know about it, but it's useful for every laryngologist to have this in their operation theater. Again, a child with bulky papillomas obstructing the larynx, and with the endotracheal tube or with the video, you are not passing there is no space to push in the endotracheal tube. In such an emergency, acute emergency situations, you can pass in the ventilating bougie and ventilate the child for 2 or 3 minutes, get the forceps, debulk the lesion, and then give the space for anesthetist to intubate and carry on with the surgery. So again, in acute obstructed airway, risk factor about the ventilating bougie and jet ventilation is chances of pneumothorax. So you should be aware of if anesthetist is not able to ventilate the child during the surgical procedure. This tube, what we are using in children with obstructed larynx, is what is called, or what has been invented by none other than our moderator, Mr. Vasant Oswal. So this is Oswal-Hunton laser resistant tube. What's the difference between a commercially available laser flex tube? This is a cuff tube and this is uncuffed tube. Especially useful in children to use a laser, and we use this tube in obstructed larynx in cases of papillomas. And I'm very proud to be associated with Mr. Oswal, who has really invented this tube. I just wanted to introduce this concept which he has propagated. So laser resistant tubes could be cuffed ones, which are commercially available now, but uncuffed laser resistant tubes could be useful in pediatric age group, especially in the cases of laryngeal papillomas. What are the surgical principles which I have followed may be useful in everyday practice? First and foremost is, you see a papilloma on the vocal cord. The patient has come with the change in voice as a symptom, not respiratory obstruction. You have taken the patient for removal of the papillomas under GA, but remember, before you start the surgery, you have to examine the entire airway with a flexible endoscope. Now this patient, I just examined the airway with the flexible endoscope, and I could find papillomas in the subglottis, in the trachea, and even in one of the terminal bronchus. So it could be, there could be some concurrent region, or there could be some multiple papillomas at another sites, or especially in the lower respiratory tract. So this is in the trachea. I just went ahead to complete the examination. I could find it in the bronchus. So examination of the airway, complete airway before you start off with the surgery. You have to first define the anatomical landmarks. This is a child with obstructed larynx, bulky papillomas. Before you use the forceps or laser or microdebrider, first you have to identify where are the vocal cords. So this is a probe, laryngeal probe, with which, now see, I have identified the vocal cord, the level of the vocal cord, and then I will start using whatever tool I have to prevent trauma to the normal structures. This is a case again in the anterior glottis, but you have to check what structures it is involving, whether it is extending into the subglottis or not, whether the anterior commissure is free or not, and then start exercising using your tools. A case of papilloma in the anterior commissure, but when I took the patient for, this is on video laryngostroboscopy, so I thought it is an anterior commissure, and I took the patient for surgery, but I wanted to check where it is originating from and what structures it's affecting. And then I could find it's originating from basically the right vocal cord. And then I limited my surgery only to this cord. It was not originated from the anterior commissure as a whole, but only from one third of right vocal cord, and then I could excise it completely. So basically, you have to check the landmarks and then proceed with your surgery. In the anterior commissure, papillomas are there. How will you go about? Basically, if you have cold instruments, better not to use them in the anterior commissure and remove on both the sides. If you want to use, you can use CO2 laser in a scanning mode. Maybe the roots of the papilloma you can pluck with angled forceps. Post-surgery, no voice rest. Let the patient phonate. And after 1 or 3 weeks, you should follow these patients. If there is a slough in the anterior commissure, you should remove the slough either with a bronchoscopy or taking the patient under anesthesia to remove the slough. This is all to prevent formation of anterior web, because you are making raw surface on both the vocal cords in the anterior commissure. So basically, the bulk of the lesion should be removed with laser, and the root should be plucked with the angled forceps. Again, in the posterior commissure, there could be chances of recurrent adjunct fixation or posterior glottic stenosis. Again, don't use laser in the posterior commissure. You can pluck the papillomas with angled forceps. If it is, this is in the interarytenoid area, so use the angled forceps to remove these papillomas and not to give any thermal damage and not to create any posterior glottic stenosis. In the subglottis, again, surface ablation with the laser, and then use angled forceps to remove or pluck the root of the lesion. Now, first you have to do laryngoscopy of each and every patient and check where the papillomas are coming from. may not be only from vocal cords or in the subglottis. Now this bulk is coming from really the laryngeal surface of the epiglottis. So first, with the video laryngoscopy, you have to check from which structures it is coming. Accordingly, you have to put in your DL scope, position your DL scope, and with the curved forceps or a diode or KTP laser, put in a curved probe. You have to remove the papillomas from the anterior surface of the epiglottis. So principle is first define from which areas it's coming, take certain instruments specific to those, and then go ahead with the surgery. What lasers you have to use? You have a CO2 laser, a pulse KTP laser, or a diode laser. So pulse KTP and diode laser are fiber transmissible, could be put into the probe and could be used in various positions. CO2 laser is a beam laser and it gives good or unobstructed view of the surgical field with minimal tissue manipulation. Now this you have to remember when you are using laser, the laser plumes can transmit the HPV virus to the surgeon's eyes. So surgeon has to be protected with goggles, though not proved otherwise, or there is no case which has been related to surgeon developing the HPV infection. But this possibility has to be thought of when you are using lasers for laryngeal papillomas. KTP laser, what's the properties? Physical properties. It is basically selective photothermolysis and angiolytic laser. Now, what's the role in respiratory papillomas? Vascularity is the most important factor for recurrence in recurrent respiratory papillomas, and KTP laser really blocks the microvasculature and promote the complete remission. So it prevents transmission or transfer of viruses to the peripheral tissue, and that's how it prevents the recurrence. Again, because it is fiber transmissible and passed in the probes, we can use it in different difficult areas like under surface of the vocal cords, in the subglottis, in the lower airways, or as we have already seen, the laryngeal surface of the epiglottis. Again, we are going to see this, but this is the KTP laser we are using. You can use it in the OPD settings as well. CO2 laser, basically AccuBlade can be used on the edge of the vocal cord to cut this incision. So any papilloma, you just have to stretch it medially with the forceps and cut it with the CO2 laser. You can just put it in the plane and separate it from the surface. If the papillomas are on the surface of the vocal cord, then you can use the scanning mode of the CO2 laser and vaporize these papillomas. This is a laser resistant tube, metal tube. So again, I'm checking from which areas the papillomas are coming using the scanner mode. This is scanning mode and I'm vaporizing the papillomas on the surface. Now always remember, the scanning mode has a minimum thermal damage. It acts like a shaver and gives good phonetry outcome. So this is pre-op stroboscopy of the patient. The same patient.
You got a couple of more minutes, Sachin?
Yeah, and this is the post-operative. Okay. Silofovir, we are going to go ahead with Samira, but it has to be given intralesional. It can be given systemically or oral or inhalational. We have already seen the dosages. Sites, actually, it has to be subepithelial space offering case, vestibular folds, supraglottic area, hypopharynx, and plaques proximal area of the esophagus. You can increase the dosage sequentially when you are giving every 4 weeks to the patients. So both these studies have shown that sildenafil has got good remission rate when it's given in the patients. Our study also corresponds to the same range. There is no risk of dysplasia, and these are the average doses. We are already going to see about the bevacizumab, but it acts as a vascular endothelial growth factor inhibitor. These are the dosages. You have to remove it laser with the cold instrument, and at the base, you have to inject the drug. Again, the same study, it gives good remission rate. It can be used with KTP laser because both these have angiolytic properties, blocks the blood vessels. So both you can remove the papillomas with KTP laser and inject bevacizumab. So both these would act in synergy and give good possible remission rate. We do have the same study with us. We have already talked about the serotyping. What are the clinical significance? Just a patient, a young patient with papillomatous growth, showing squamous cell carcinoma without any risk factor. Remember, keep in mind, you have to send this for HPV subtyping or typing. Around the 12 patients, actually young patients showing papillomatous growth. We removed them, send it for HPV, turned out to be squamous cell carcinoma. 10 of them actually turned out to be HPV positive. The idea is these are very radiation sensitive and all patients are doing well with radiation. These are already talked about. These are available in India. First point is actually malignant transformation. So it's a benign disease. All the studies which are available, publications which are available, mention about 1 to 3% of adult laryngeal papillomas turning into malignancies. Not a single case of RRP has turned into malignancy in the literature. We have done our own study, and around 5 patients in 120 adult laryngeal papillomas have turned into the malignancy. You have to always see to it whether these are smokers or have any history of radiation. Most of them do have smoking and history of radiation. You also have to do these P53 and other biomarkers. Okay. I think the studies about the remission rate can be improved with laser, and these are our studies. I think, thank you for patient hearing, and I will ask Mr. Oswal to
Thank
continue.
you. Thank you, Sachin. It's a wonderful overview of a lot of problems that you covered in a short time. I think we will reserve some discussions in panel discussion that follows. But we have now Dr. Samira Bain, who is in Mayo Clinic. She's a consultant there. And there are Brandon and Samira have worked under or with Steve Zeitel. Of course, Steve Zeitel is a big name in America. And I think it's quite fortunate that you do have worked in that department in Massachusetts. So we're really fortunate to have these people with such an experience from States and, of course, from India to cover this rather difficult topic. So if Dr. Samira, you can talk about yourself a couple of minutes if you want to. Otherwise, we'll go on your office-based KTP laser ablation of papilloma. In my days, in the 80s, when I started the laser in 1982, there were no fiber optic mediated lasers at that time, only acute laser. And of course, you could not do the procedure on office-based papilloma management. Now, office-based papilloma management has some advantages, particularly it's cost-effective and also patients like the procedure, do it on an office base and then go home late in the evening. But there's more to it than that, and I'm sure Dr. Bayan or Samira will tell us a bit more about how to go about it. If you do decide to undertake this office-based procedure, I think you need to follow certain protocol to be on safe side. Thank you, Samira.
Thank you so much, Dr. Oswald. Thanks to Dr. Barrett, Dr. Gandhi, and also Dr. Barathi. It's just a pleasure to share the audience with you guys and be on this esteemed panel. And I appreciate you sharing some time with me today. I am Dr. Samira Bayan. I am an assistant professor at the Mayo Clinic in Rochester, Minnesota. I also help run our residency program as our associate program director. I'm a laryngeal surgeon. And a good part of my practice is in-office work. We're lucky enough here to have a KTP laser in our office. And so I perform in-office laser procedures not only during my regular clinic day, but have 2 days a month where all I do all day is different in-office procedures, including office-based KTP laser for papilloma, which is what we'll focus on today. So as Dr. Oswald says, there's benefits and negatives to doing in-office procedures, and it's not for every single patient that you see. There's good candidates and poor candidates. In my mind, a good candidate is someone who has a relatively low disease burden, and that's basically means that the procedure would take less than about 30 minutes. In my experience, patients can't really tolerate an in-office procedure much longer than that. If they must have a prior biopsy proving that there's a risk for papilloma. As Dr. Gandhi had mentioned, obviously, you want to make sure that you're not missing something else, such as a cancer that is masking itself as papilloma. The patient should have the capacity to follow directions because it is a bit of teamwork to be able to get the patient to cooperate with the procedure, and you should be able to effectively control their gagging and coughing with topical anesthetic and anxiolytics, which we'll talk about later. Poor candidates are patients with a pretty high disease burden, and I'll show you some pictures so it kind of differentiates between the two. If there's concern for other pathology or if you have papilloma that's within the tracheal airway or challenging to be reached, such as underneath the glottic web. And then obviously patients who have high anxiety levels or just can't control their gag reflex. I have a patient who you can't even get near his teeth without him gagging or put the scope near his nose without him gagging no matter what you do. And that's just a poor candidate for an in-office procedure. And obviously if the patient's actively ill or nauseous, that's also not a good idea to numb their throat during that time. So here's some examples of, for instance, obviously this is someone who you would not be wanting to perform an in-office procedure on our right hand of the screen, and a reasonable candidate and someone who has a few lesions of the vocal cord. Here's another example of a few supraglottic papillomas and then ones within the glottis. And then this is a little less clear, but as you can see here, the patient has papillomas that's almost crossing the anterior commissure. I tend to not do these, even if it's a reasonably low burden of disease in the office, because you can run the risk of creating an anterior glottic web. So there are some benefits, as Dr. Oswald mentioned, with in-office laser procedures. Number one, it's considered safe. It does allow you to treat small areas of disease before a patient has large changes in their voice, which can be beneficial, especially for people who are professional voice users, such as teachers, lawyers, physicians. And the patients also avoid trips to the operating room. It is cost effective. They miss less work. There's less need for childcare, elder care, and a quicker recovery. For instance, I have one patient through our American insurance company who has to pay only $30 to come in for their in-office procedure every time they do. So it's clearly a cost benefit for them. So for me, the preparation is key. So I like to create a very relaxed environment when I'm performing an in-office procedure, and that means I'm relaxed and the team that's in there with me is relaxed. I like to explain every step to the patient. I have a pretty low threshold to provide pre-medication to the patient if I feel it's safe and the patient's medical status makes it appropriate. For very elderly patients, that may not always be ideal. I tend to use diazepam at about 2.5 to 5 milligrams, and I'll vary that based upon how much alcohol use the patient has, because that could lead to tolerance of the drug. And then if that is the case, I will make sure the patient has a companion to drive them home, as they should not be operating a vehicle for the rest of the day. I do dim the lights during a laser procedure. I'll play music for the patient, often music of their choice. And we do a lot of physical touch if the patient allows it, meaning I'll have my nurse or other colleague rub their back while we're doing the procedure, help them relax their shoulders and give them verbal reassurance. The biggest thing is you don't want to rush the beginning part, which is making sure the patient has appropriate topical anesthetic. So it's very easy to place your lidocaine and then want to get started right away. But sometimes I'll do that and then take a couple of laps around my clinic room to give myself some time and to exercise patience before we get started, so we can make sure that the anesthetic is instilled and ready to go for the patient. I use transnasal lidocaine and decongestant in the nose. And then this is an easy spray that we can hook up. You can hook up to an oxygen or even a nebulizer machine that allows an atomized spray. It has a flexible nozzle, which I find convenient. So you can do transoral and transnasal spray. And then I'll also instill some 4% lidocaine through our channeled scope prior to starting the procedure. You can also consider transtracheal injection as well. For patients with a strong gag reflex, I'll sometimes put a small amount of benzocaine on the base of their tongue, because that tends to be where most people have the most active gag. And then this is very anecdotal, but I tend to find putting salt on a patient's tongue can be helpful. And I cannot explain neurologically why that's the case. I think it's probably a different texture and flavor for the patient's brain to focus on. But if someone's really struggling with gagging, I will put salt on their tongue, and that most of the time actually tends to work. And then we do a test run before starting, meaning before I start lasering, I'll get close to where I'm going to be lasering or even touch the lesions I'll be lasering to make sure the patient is not sensitive in those areas. So Dr. Oswald had also mentioned it doesn't come without complications. And while most of these procedures run smoothly and seamlessly, you want to make sure you're prepared for anything that would happen. Probably the most common is a vasovagal reaction. I try to prevent this by first checking in with the patient periodically. So just say, how are you doing? Are you feeling okay? Are you feeling nauseous? If they in any period of time seem to feel uncomfortable, stop. I have a team member in my room. It's usually a nurse who's also watching the patient, because sometimes if you're looking at the screen, you can't always see the patient, who will alert me if they think maybe the patient's looking a little pale or not feeling well. And then I have the patient communicate with me too. If they're not feeling well, sometimes I'll have them tap my leg so they don't have to speak or cough, and just let me know that things aren't going well for them. The most important thing is to be ready and not panic. You want to have a chair that can lay back quickly if you need to. You want to elevate the patient's legs. You want to be able to have equipment that you can get vital signs. And then we have easy access to some disposable ice packs and a fan that we can place for the patient. The other thing you want to worry about is the fiber breaking within the airway. Prevention for that is I usually keep the fiber pretty close to the end of my scope. I like to watch and kind of check and make sure that the patient's not preparing to inadvertently swallow or cough. And if they do, I'll quickly pull the fiber back. And then I also, like I said, have the patient signal to me. So if they feel like they want to cough or swallow, I just have them tap my leg so that I can pull the fiber back and get out of the airway. But what happens if the fiber breaks? Well, you can have the patient spit it out if they can, though you can run the risk of them being pretty numb and not being able to, or you may have to retrieve it if it is in the airway. The last complication I'll discuss is lidocaine toxicity. While rare in the adult population, you still want to be aware of it. And most often you'll see this in patients who have some liver disease, as they won't metabolize the lidocaine quite as appropriately. Early signs can include numbness of your tongue, circumoral numbness, dizziness. They can start to feel blurred vision or having ringing in their ears. Restlessness, agitation, or paranoia are some more excitatory signs. And in the most severe state, they'll become unconscious or have a coma. Treatment for this is 100% oxygen, which you can usually administer in clinic. The benzodiazepines we administer, thankfully, can also help as prophylaxis for seizures. And then you want to manage cardiac arrhythmias. And when they're in an acute setting, ICU setting, they'll utilize lipid emulsion therapy. The other thing you want to be aware of is methemoglobinemia with products like lidocaine and benzocaine, and have methylene blue available, of which you'd be dosing this 1 to 2 milligrams per kilogram within up to 50 milligrams as a 1% solution in saline, and you do that over 3 to 5 minutes through the IV. So to prevent the dreaded lidocaine toxicity, you want to be aware of the patient's medical comorbidities, as I mentioned, hepatic disease, any renal failure, heart failure, or pregnancy. You want to be aware of the maximum dosing for patients with ester drugs such as benzocaine or lidocaine, as well as the canes like lidocaine. Other safety tips, I like to have at least one other member of a team in a room. I don't generally do this alone. This helps someone not only help run your laser, but also be able to watch the patient with you. You want to have emergency equipment available, even though it's rarely needed. That includes equipment to observe oxygen saturation and blood pressure, having a fan and ice packs, and then a resuscitation cart easily available. Though again, it's very rare to have to use this if you're picking the correct patient. And then you want to make sure your entire team is educated on laser safety. So tips for in-office laser, you want to match your lasering to the patient's respiratory rate, because the patient's vocal cords will often move while they're breathing. I attempt to first blanch the papilloma and then remove at least portions of it first, and then clean my fiber periodically. And then I use both my suction and the patient throat clearing, which can help remove papilloma as well. I'm going to show you a few videos of each of these techniques and examples. My preferred laser is KTP in the office. And on the vocal cords, especially near the anterior commissure, I'll tend to use it at 30 watts. If we're more at the mid or posterior cord, we can move it up to 35 watts in a pulsed fashion, 15 milliseconds, 2 pulses per second. And then for supraglottic papilloma, you can turn it up even higher. I usually go up to 40 watts. I won't linger too much on adjuvant therapy, as has been discussed very thoroughly by Dr. Barathi and Gandhi, but I will use in-office bevacizumab at a dosing of about 6.25 to 12.5 milligrams per area where I'm injecting. And then cidofovir can also be used, and there's varying doses for this. I can do this either through a transoral injector or through a needle through a channeled scope. Many of my patients aren't really tolerating a transoral injector after a full laser procedure. So I have been actually using a needle through a channeled scope, which sometimes can work quite well. So I wanted to show you all just some techniques that I like to use in an in-office procedure. So this is a patient with that we had seen a picture of earlier with some papilloma along the medial edge of their cord here. And here you're going to see blanching of the papilloma. And then we'll have the patient throat clear, but then I'll also suction, and that'll effectively remove most of the papilloma. Now, all that being said, with in-office procedures, you're not necessarily removing 100% of the lesion all the time. Sometimes you're leaving just a bit of blanched tissue, and that's fine because a lot of that will slough off for the patient, and they can still have a very nice result. And so here you see we're working on blanching, and as you can watch, the patient is breathing. We're trying to match their respiratory rate. The fiber is relatively close, so you can't even see the end of the cleave of the fiber. I have it kind of so close to the scope here again, just to ensure that there's a lower risk for breaking. And then in just a moment here, we'll pull the fiber back, and then I'll have the patient do a throat clear and we'll suction. This can be quite effective. Your fiber can sometimes end up getting some debris on it. You can pull the fiber back and suction within the scope, and that can sometimes clean the fiber. Other ways is just to remove the scope completely, but you want to make sure you don't have a lot of debris on the end of the scope, or it can really slow down your procedure. And so here we'll have the patient throat clear. And then they still have just a little bit of papilloma there. And so we'll take the suction that effectively removes the papilloma. This is using, utilizing the laser to gently remove the pieces of disease, and I'll move forward here. So here we can see we're kind of using the fiber to gently peel off portions of the papilloma just from the epithelial layer. And as we move further on, we've now peeled it further off the layer. And then I kind of attach the fiber to it, do a gentle pull, touch just the area where we've blanched, and again, and then one more time to grab the rest of this. And then lastly, as I said, you can perform both transoral to the right and then through a channeled scope, Avastin injections into the intraportal Avastin injections into the vocal cord. And here you can see a subepithelial injection of the Avastin. So after the procedure, I don't usually put the patient on voice rest, but I'll just have them take it easy on their voice, not to do any heavy voice use for that day. I encourage them not to eat or drink for 2 hours. And I have candy here because we have candy in our office that I'll actually give the patient after the procedure so they can have something in their mouth, but not necessarily something that they're going to choke on. It's mainly just like their saliva, and that goes over really well. And everyone enjoys getting a lollipop after they've been to the doctor. I encourage patients not to drive if they've had pre-medication. And then I get some feedback from them to see how the procedure went for them and if there's things that we could do better, if there's somebody who is going to come back again. And that just gives them, you have a greater chance for success and more buy-in for the future. Briefly, I was asked to discuss the systemic Avastin. It's one of the newer treatments, at least within the adult world, though I think it's used most commonly in the pediatric population. But there's certainly a population of adults where this could be beneficial for, and there's been some nice larger studies looking at kind of the consensus on the patients who are good candidates for this. In general, I have 2 patients right now in my practice who I utilize systemic Avastin for, and these are people who either need debridements very frequently or people who are challenging airways, meaning they have distal tracheobronchial lesions, or potentially putting them to sleep could be life-threatening. And this is an example of one of my patients. To the left here is a patient who not only had a prior trach, but has tracheal stenosis, has a very difficult airway, has a challenging mask, and a very challenging direct laryngoscopy. And so for him, he was having troubles with breathing. He also was a marijuana user. And so we used systemic Avastin, and this was after his first 6 weeks of treatment with significant improvement in his airway, as well as papilloma disease burden. So that's all I have. I thank everybody again for their time, and I'm very happy to answer any questions if there are any.
Thank you very much. Thank you. Thank you for excellent presentation, Samira. Now we start with the panel discussion. I think we'll have to cut it down to only a few topics because the time is getting on. Maybe first question I have for Samira. In the US, you need to have admission privileges for the local hospital before you start outpatient. Is that right, isn't it?
I believe so. It depends on the practice that you're a part of.
I think maybe it's necessary to mention that, particularly for the rest of the audience of this webinar, that you need to have access to a hospital nearby just in case patient collapses while you are doing the outpatient surgery. The next question I have is, or observation is, Dr. Sachin Gandhi said about surgeon getting implantation papillomas. This question was addressed way back in the 80s, and I think there were 2 reports from Scandinavian surgeons who developed papillomas or condyloma around the mask. But that's about the only 2 reports that I have. I don't think there are any other reports in literature to mention that there is this possibility that exists. Particularly whether the papilloma virus is viable when it comes out in the plume, or it is morphologically maybe viable or it looks viable, but biologically, is it viable? We did some study on that, but it's not published. But there's the incubation of those viruses or viral structure, I would say, from the plume did not produce any further papillomas after incubation period. So that's an observation. There is, sorry, go on. Sachin, you want to say something? No. The other thing I think is, if you do go on using the laser and the patient has very frequent recurrences, then there's no doubt that some of the tissue, some of the normal tissue is lost to maybe a couple of 100 microns or more. But I think there comes a stage where you would not use the laser because of loss of normal tissue. That doesn't happen with cold instrumentation. So these are a couple of observations I have, and I would invite our speaker to comment if they have any on these observations. The last one I have is the children have the schooling. And do you have, sorry, let me finish the last question and then I'll get back to you, Professor Bharati. The last question or observation I have is, these children have problems in schooling, hoarseness, repeated admissions. Do you have a liaison with the school on that basis, or do you tell parents to have liaison with the school teacher, headmaster, that there is a problem? Because many times their children are victim of harassment by their friends in the school, so they need a bit more care by the school. So please, any of you can contribute to these 4 observations. Thank you.
Yeah, it's a nice suggestion, Dr. Vasan sir. I think because we are doing many school programs over here, I think we can include this also. I think, thank you. We'll start doing it.
Yeah.
Well, actually, this goes back to laryngectomy that I used to do, total laryngectomy in 70s. And rehabilitation after laryngectomy is nobody's baby, apart from a voice therapist. So I developed a protocol, which is known as team concept of laryngeal cancer, so that you can follow the patient occupation and get in touch with the works medical officer to say what disability the patient would have. I even went to the extent that I went down 3,000 feet in the mine to see the working conditions of one of their workers who had a laryngectomy. Potash mine here. The seam comes up here in northeast of England, and the other seam goes into Germany under the sea. So these are the issues of follow-up, particularly disability that it produces. Anyone else want to comment on anything else? If not, then I would like to open up the topic maybe another couple of minutes or more. We all aware of artificial intelligence that's going to take over in a big way. And the presentation today, maybe 50% of it was more theoretical than practical. And that theory, I think you can type a couple of queries to GPT 3 or 4 or even 5, and you will get all the answers that you presented as a theory. So maybe you want to think about the future and say what kind of training I'm going to give to our junior doctors. Now, I remember somebody said on the program, AI won't grow food. So that's a place that humans will have to do that work. And I would add surgery to that as well. I know robots are there to do surgery, but then they're not there to do everyday surgery of papillomas here and there. So I think surgical part, practical hints that you can give to our future surgeons rather than say whatever you want to say about the theory, which is available in 30, 40 seconds by using GPT-3 even now. So I would like to suggest that the future is different for training purposes. I think you should concentrate maybe on showing how actually you do the work rather than say all about the theory. So these are my suggestions. I think, Sachin, any of you want to say anything more about that? Please go ahead. No?
Yes, sir, you're right. You're right. It should be more of a practical demonstration and discussion.
Yeah. You see, my career started in 1955 in medicine, when penicillin wasn't even around easily. And then I was trained to mastoid surgery with chisel and hammer. And we come a long way in the last 60 odd years. And of course, these techniques are wonderful. Have you got any questions from the audience? Couple of questions before we finish?
Yeah, actually, we have got few questions. Around 40 questions, but most of them have been already answered in the various talks. There are few questions. What is the dosage of celecoxib and whether it is safe to use it in children? So I think it's safe to use in children, and there are dosage for 400 milligrams per day in adults to around 100 milligrams in children less than 15 kilograms, and this should go in for 1 year. There is another combination available in the market. Am I right, Dr. Bharti?
Yes, sir.
Yeah. And there is another combination of celecoxib available with erlotinib, but it can be used only in adults. So it is very well in use in the market and available in market. And Dr. Bharti, Dr. Brandon, whether it's safe to use do hydrodissection while excising the papillomas. Dr. Bharti, there is one question from Dr. Murthy.
There's no need, sir, because we are not doing any subepithelial dissection here. On the surface of the epithelium or wherever the lesion is there, we are removing it. So hydrodissection, I don't think it's required in this. Whereas if you have just a small lesion, papilloma, maybe, but hydrodissection, I don't think is advisable. Only subepithelial injection of the drug is advisable.
I respectfully disagree with Dr. Barathi. I tend to do a lot of hydrodissection for all of my papilloma patients, both at the beginning and then also at the end of the case. The beginning of the case, I feel like it gives me a little bit, a couple of microns more thickness of safe space to kind of get down to that sort of papilloma epithelial junction and be able to determine what normal tissue is and what sort of abnormal tissue is. Additionally, when I'm treating with the KTP laser, I find that I have a lot more of a treatment effect and sort of a normal sort of recognition of papilloma responding to laser versus normal epithelium responding to laser when I have the tissue under tension. So I tend to use it pretty frequently throughout the case. And then I also, as you do, inject bevacizumab at the end of the case and look to see what degree of superficial lamina propria has been preserved to kind of have a prediction of the voice outcome for patients.
I think that concept of not injecting came from maybe spreading the papilloma and the surrounding tissues. Now, when I started, of course, we used to call it laryngeal papilloma, then we changed the name to recurrent respiratory papillomatosis, in the knowledge that the virus resides in the respiratory mucosa rather than you are implanting it around the tracheostomy hole or anywhere else in the larynx, because there are not cases which the surgeon has spread. If the virus is active, juvenile, for example, up to 12, 14-year-old, and then there is an adult papilloma. So by injecting hydrocortisone, by injecting saline or any other drugs, I don't think there is any danger of spreading papilloma. So I think I would tend to agree with Brandon. Thank you.
Again, Dr. Bayan, you already talked about this, but again, patient selection for intralesional Avastin and dosages. I mean, few of the points in summary, if you can repeat, yeah, because this has been questioned by half of the recurring Avastin. there are many queries coming over.
Yeah, in general, I'll tend to select patients who, or they're requiring laser procedures less than 3 months apart is kind of my indication of considering Avastin injections. And I'd be curious to hear what everyone else does, but that's kind of my threshold for Avastin injection. Is in regards to the frequency, I don't think there's a lot of really great data out there yet as to how often we're doing it, but you can start every 6 to 8 weeks and then lengthen the amount of time, which is what I tend to do. And I like to get as long of a period of time as possible. So first we'll do in 8 weeks and then 3 months, and then maybe try every 6 months, and then maybe every year if the patient can go that long. Dosing is also variable, but you can use between 6.25 to 12.5 milligrams in the vocal cord. I do think there's evidence to show that you can use up to 25 milligrams in the cord safely. And then I inject it subepithelially into each section, and that means supraglottis, each vocal cord, false cords. I hope that answers the question.
Okay,
Are they-
and maybe last question, because all are been answered. Is the recurrent nature of disease responsible for malignant transformation? Maybe Brandon or maybe Samira, madam.
We know that disease that's more recurrent, specifically the HPV-11 phenotype subtype tends to be more prone to malignant transformation. I'm not sure I exactly understand what the person is asking, but if you have more aggressive disease, specifically HPV-11, then you should continue to surveil and continue to be suspicious for malignant transformation. I don't think we can identify causality though.
Yeah.
I think you're right, Brandon. There are two different serotypes. The 16, 18 gives malignancy, not particularly recurrent cases. I don't think that's proven at all. Sachin, anything else?
Yeah, I think the malignant transformation, I've already read about it. It says there is a disparity whether it is a primary or secondary. I mean, it could be a primary malignancy also when diagnosed, or maybe whether it is secondary to papillomas is also in discussion. That's number one. Number two, more commonly seen, whatever 1 to 3% transformation has been reported, there are only 3 papers available of transformation into malignancy, 1 to 3%. So there are only 6 or 7 cases which have been published as of now. Half of 4 to 5 of them are smokers. So whether it is the smoking which is responsible for malignant transformation. So whatever we do in our practice is when we get these patients, we ask them not to smoke, either active or passive, and be apart from chemical or other risk factors known for laryngeal papillomas.
I'll give you my experience. If any papilloma, which is recurrent papilloma, and one of these visits of the patient to your hospital, you find that particular papilloma is bleeding and friable and also comes back very quickly, then be sure that that's malignant transformation. I think particularly the bleeding and friability is the hallmark of transformation of papilloma into malignancy, and you always be look out for it. It doesn't, your eyes will tell you there's something different. Take a biopsy, send it, and then confirm it. And if the biopsy comes negative, and if your eyes actually say, no, I don't agree, send a second biopsy, because these are fatality cases. They're not good cases, when they transform into malignancy. So I think we're nearly concluding, are we, Sachin, now?
Yeah, I think
I just want to thank you.
Sir, I would like to announce the next seminar.
Oh, yes.
Yeah. Now for all the participants, I'm very happy, and I would like to thank the attendees. The number is more than 1,000 live participants at any moment. There are more than 2,000 registrations I could see. So I would like to thank all of them. Anybody who has missed any of the lecture, all these lectures, this webinar would be available on the website and link would be sent to you on your email. We'll have a next session on 18th of August 2023, same time for Indian participants in the evening 5:30 to 7 p.m. The topic is unilateral vocal cord palsy, and detailed program would be available soon on the link. About the certification, after every 4 sessions, we will have multiple choice questions available on the link, which every participant or those who want the certificate, they should attempt the MCQs and they will get the certificate. They can print it on their own. So after every 4 sessions, the certification will be given. I will hand it over to Mr. Oswal.
Yeah, well, I think just to finish it off, Pune is my hometown. That's where I come from. That's the relation between Sachin Gandhi and myself. And there's a charity hospital, 1,000-bedded hospital that was established in the memory of a Bollywood singer. And they asked me to develop that department 20 years ago. I'm glad to say that the quality of the department, education, is something that Royal College of Surgeons of England have approved as an accredited center for education of his hospital. And this is the only hospital outside UK and Ireland in the world which has been approved by Royal College of Surgeons of England. So I think really we're very grateful for our participants, to Professor Bharati and Samara Bain and Brandon Baird, and particularly Van Bengen, that having a joint webinar between your institution and our institute there in Pune is very rewarding, and we hope we continue this. So thank you again, all of you, and special thanks to Dr. Gandhi for making these webinars happen, which is quite a hard work, that we understand it. Thank you. Thank you all, and goodbye. Have a good week. Have a good weekend. Yes, it's weekend. Okay.
Yeah, we can.
Thank
Okay.
you.
Thank you.
Thank you also.
Bye.
Bye,
Thank you,
Dr.
Samira.
Sachin.
Thank you,
Bye,
Brandon.
Brandon.
Thank you,
Bye.
madam.
Bye.
Bye, thanks for having me.
Bye.